We are happy and very proud to have Dr. David Wen as our second speaker. Dr. David Wen is a National Institute for Health Research Academic Clinical Fellow in Dermatology at the University of Oxford and Oxford University Hospital in the United Kingdom. Dr. Wen completed preclinical medical training at the University of Cambridge, clinical training at the University of Oxford, and subsequently undertook general medical training in London at Ealing and Chelsea and Westminster hospitals. This was followed by a dermatology fellowship at Solihull Hospital, where he completed a Master of Research in Clinical Health Research at the University of Birmingham. His research interests include the use of artificial intelligence to improve skin cancer diagnosis and genotype-phenotype correlation in genetic skin disease. And today he will talk about some of his recent work on characteristics of publicly available skin lesion datasets. So thank you very much for being here today, and the floor is yours.
Thank you very much for the invitation and the introduction. Let me just share my screen. Okay, can everyone see that? Yeah, okay.
Yeah, that's good.
So yeah, thanks very much again for the introduction and the invitation. I'm David Wen, a doctor from Oxford in the UK, and the title of my talk today is Characteristics of Open Access Skin Cancer Image Datasets, Implications for Equitable Digital Health. So in this talk, I'll give a quick overview around AI algorithms being used to diagnose or to help diagnose skin cancer. And then I'll outline the methodology and results from our systematic review, which investigated the characteristics of open access skin cancer image datasets. I'll discuss implications of our findings for patient care and digital health equality, and what steps we can take to ensure that digital health datasets and the technologies that are developed from them can benefit all individuals. And as you guys may be aware already, there's been a lot of excitement around AI diagnosing skin cancers, as seen here in scientific journals, also in the mainstream media. Numerous apps claiming to be able to diagnose skin cancer have also made their way into app stores as well. And this has really taken off in the last 6 years or so, mainly being driven by the use of deep neural networks, which require large numbers of digital images for algorithm training. Open access skin image datasets are frequently used to develop AI algorithms for skin cancer diagnosis. And these datasets are often utilized because they circumvent some of the barriers associated with large-scale image acquisition, which include having appropriate technological infrastructure, regulatory approvals, time, and money. And furthermore, another advantage is that publicly available datasets can be used as a benchmark for direct comparison of algorithm performance. So how often are these publicly available datasets used? And this is a figure from Dr. Dineshji's paper, which she has shown already, so I won't go into much detail. But if we look at the proportion of studies that used publicly available datasets, this was 40 of 70 papers, or 57%. And as Dr. Dineshji has mentioned, her review also found that some datasets, in particular dataset 1 here, called the ISIC archive, are popular, and they've been used multiple times to develop algorithms. So whilst open access datasets are a valuable and easily accessible resource, algorithms can be susceptible to overfitting when trained with data from circumscribed populations, and their generalizability is heavily influenced by the subjects and the images used in their development. Images in these open access datasets are often curated retrospectively, and they're susceptible to selection bias. And it's been demonstrated that algorithms used for skin lesion classification underperform when tested on external independent datasets to which they were trained on. In this South Korean study by Han et al., the authors trained an algorithm on tens of thousands of skin cancer images from a South Korean population. And when tested, the developed algorithm performed well on images from a similar South Korean population with an accuracy of 0.96 for melanoma diagnosis. However, when tested on images from a UK population, this algorithm underperformed with an accuracy of 0.88. And this is the study by Dr. Dinesh, which she talked about earlier, which found something similar in that a state-of-the-art algorithm that was trained on an open access data set called HAM 10,000, which contained images from predominantly Caucasian individuals from Australia and Austria. This was tested against an independent diverse skin data set from Stanford, which contained images of skin lesions from individuals of all skin types. And as you can see here, the accuracy was fairly good when tested on the same data set from Australia and Austria. But then when tested on the external data set, the accuracy decreased from 0.92 to 0.67. And notably, when evaluating performance by skin type, the authors found that lesions from darker skinned individuals with Fitzpatrick skin type 5 to 6, accuracy was substantially worse compared to lighter skinned individuals. And as Dr. Dinesh mentioned, they fine-tuned the algorithm with images from their own data set, which contained images from individuals with both lighter and darker skin. And when they retested the algorithm, its performance for both lighter and darker skin types improved when training did include lighter and darker skin. And this again highlights how algorithms are affected by the data that they're trained on. So when thinking about algorithm generalizability and deployment for clinical use, it's incredibly important to know about the training data used, specifically the dataset composition and the characteristics. Dataset and image metadata, such as these labels here on the right, provide information about the disease and population upon which an algorithm was trained or validated on, which is essential for extrapolating assumptions of generalizability of algorithm performance to other populations. Furthermore, some studies have shown that classification accuracy of algorithms improves when subject and lesion metadata are integrated into models, and this more closely reflects clinical practice. As dermatologists, we take a history and evaluate skin lesions via multiple modalities, including visual examination and dermoscopy, rather than just through image analysis alone. Some publicly available datasets, such as those hosted by ISIC, are fairly well known within the dermatology and machine learning communities. However, the total number of datasets globally, their access requirements and their respective content was previously unclear. Therefore, we performed a systematic review with the aims of firstly identifying publicly available skin image datasets used to develop AI algorithms for skin cancer diagnosis, to categorize their data access requirements, grouping them into open access datasets and restricted access datasets, and then to systematically evaluate their characteristics, including associated image metadata. How did we approach this? The first step was to identify datasets, and this was done through two methods. In the first method, we searched MEDLINE for articles describing publicly available skin cancer image datasets, and also for articles describing AI algorithms used to diagnose skin cancer, which used publicly available datasets for their development. And a simplified outline of the search strategy is shown here in this table. Our full search strategy is available in our paper published in The Lancet Digital Health. In the second method, we undertook a search using Google and Google Datasets with keywords such as skin cancer dataset and melanoma dataset. And we took a pragmatic approach and continued to review search results until no new datasets were found in 20 consecutive pages. To be included for data extraction, datasets had to contain non-radiological skin images of skin cancer, and datasets of histopathological and radiological images were excluded, along with datasets which didn't contain images of skin cancer, such as datasets of skin rashes or benign lesions only. Identified datasets meeting inclusion criteria were then grouped into two categories. The first was a regulated access dataset group, which included datasets requiring payment, formal institutional agreements, or ethical approval. And the second group were open access datasets, which were freely accessible or easily accessible via registration or email. And the open access datasets were subsequently reviewed regarding their general characteristics, and also for what metadata was available for individual images. Some of the characteristics are listed here and included country of origin, imaging modality, and publication date. And metadata labels reviewed included age, gender, body site, ethnicity, and skin type. When reviewing datasets, 2 independent reviewers looked at any papers describing the dataset, along with any metadata files which contained individual image metadata, such as the table shown here on the right. And as an example for this dataset, we can see that all the skin lesion images listed here have data for age and body region available, which are outlined with the green arrows at the top, but not all of them have data for gender or Fitzpatrick skin type available. What did we find? Starting with dataset identification, MEDLINE search returned 1,897 articles, which were screened by title and abstract by 2 independent reviewers, and 584 full-text articles were subsequently reviewed. And from these, 26 datasets were identified. Moving on to the Google search, 400 web pages in total were reviewed, and from these, 25 datasets were identified. Combining the results from the 2 searches, 22 duplicate datasets were excluded, and that left 29 individual datasets included for review. Attempts to access data at source revealed 8 regulated access datasets, and of these 8 datasets, 6 required ethical committee or institutional approvals, 1 required a fee and licensing agreement, and 1 required a private competition invitation. Overall, 21 open access datasets included images that could be downloaded without barriers and were included for data extraction. And the rest of this talk will focus on the open access datasets that we identified. 14 of 21 datasets detailed country of origin, and of these, 11 originated from 1 country only, and 3 datasets contained images from multiple countries. From this figure, we can see here that the majority of datasets were from Europe, North America, and Australasia. Looking at other key dataset characteristics, year of publication was available for 20 of 21 datasets and ranged from 2013 to 2020. 95% of images were published in 2018 or later, and there was an increasing trend in the number of images published per year. Imaging modalities were primarily dermoscopy only or macroscopic photographs only, with only 1 dataset containing paired macroscopic and dermoscopic images and 1 dataset containing paired light field and dermoscopic images. What proportion of datasets reported key characteristics? Completeness of reporting is summarized in this figure. And starting from the top, year of dataset publication was the best reported characteristic and was available for 20 of 21 datasets, which was 95%. This was followed by the ground truth method used to assign diagnosis labels, and also the reason for image acquisition, such as clinical care or research. And these 2 characteristics were both reported in 16 datasets. Source of data acquisition, such as the institution where images were taken, was available in 15 datasets. And as mentioned earlier, country of origin was described in 14 datasets. Inclusion or exclusion criteria was reported in 12 datasets, and device used for image acquisition, such as the type of camera, was also reported in 12. Ethical approval was explicitly mentioned for 10 datasets, and the number of subjects in the dataset was reported in 8, as was the data collection period for image acquisition. Collection of individual participant consent was explicitly stated for 7 datasets, and whether images were processed or adjusted was reported in only 4 datasets. Overall, the 21 open access datasets contained 106,950 skin lesion images, and 14% of the images were of skin malignancies. Reviewing individual image metadata, information was available for sex in 78% of images, age in 76%, and body site in 74%. Ground truth diagnoses were confirmed through histopathology for 69% of malignant lesion images and 20% of all images. Fitzpatrick skin type data were available for just 2% of images and patient ethnicity for only 1%. And not only was Fitzpatrick skin type poorly reported in datasets, but of the images that did report this, it was very poorly representative as well. Of the 2,436 images from 3 datasets where skin type information was available, only 10 images were from subjects with type 5 skin, and only a single image was from an individual with type 6 skin. And the ethnicity of these individuals was either Brazilian or unknown. Of the 2 datasets containing data on ethnicity, which was 1,585 images in total, no images were from subjects with an African, Afro-Caribbean, or South Asian background. And coupled with the unequal geographical origins of datasets, there was massive underrepresentation of images from darker-skinned populations. What implications do our findings have for patient care? In summary, we found that reporting of metadata was limited and variable across datasets, which has implications for algorithm generalizability. And this is not just a problem in dermatology, but this has also been found in ophthalmological image datasets too. So in a similar review by Khan et al., who reviewed 94 open access ophthalmological image datasets containing over 500,000 images, they found that key metadata items such as inclusion criteria, age, sex, and ethnicity were reported in less than 20% of datasets. And as mentioned earlier, algorithms are heavily dependent on the data that they are trained on, and therefore datasets should be transparent regarding where and who images originate from, along with how images are taken. And this can be achieved with accurate and complete reporting of dataset and metadata characteristics. Thinking about reasons why metadata reporting was limited, this could be because of the significant time, effort, and approvals required for metadata collection. But at the time the systematic review was completed, there was a lack of consensus guidance and standards for which metadata items were most important to report for datasets. And to this end, it's encouraging to note that organizations such as ISIC are exploring this area through their metadata and DICOM working group. And furthermore, shortly after our systematic review was completed, the ISIC AI working group released a consensus statement for various domains that should be addressed in any image-based AI dermatology study. And this included recommendations for including metadata on ethnicity and skin color, how the data was obtained, and whether there are any implications for generalizability and bias. Other than limited and variable metadata reporting, our findings also highlight potential biases and poor representation of certain groups, both amongst and within datasets. Health data poverty is a recently developed concept and is an emerging problem in digital health. It's defined as the inability for individuals, groups, or populations to benefit from a discovery or innovation due to a scarcity of data that are adequately representative. Of the datasets that had metadata available, datasets had restricted population representation and substantial underrepresentation of darker skin types. This is also reflected in dermatology educational resources and images of COVID-related rashes published in the literature. And this bias is especially concerning as prevalence, presentation, and types of skin cancer varies in skin of color populations with associated poorer outcomes. The publicly available ophthalmological datasets identified by Saad Khan et al. Were also unevenly distributed globally, predominantly originating from North America, Western Europe, and China. In another study, US datasets used to develop AI algorithms for image-based diagnostic tasks were found to have disproportionately originated from 3 states: California, Massachusetts, and New York, and there was little or no representation from the remaining 47 states. And the authors argued that individuals from these areas may have economic, social, ethnic, and cultural features that aren't representative of the entire country, and that algorithms trained primarily on patient data from a small number of states may generalize poorly to other populations. So the danger here is that if biased data sets are used to train algorithms, the resulting digital solutions could preferentially benefit certain populations that have access to advanced data infrastructure, whilst neglecting data-poor subpopulations who may be excluded. Harm through misdiagnosis could even be caused if algorithms are deployed in populations that they were not intended to represent, and this risks widening a digital health divide and exacerbating existing health inequalities. Encouragingly, more recently developed datasets are heterogeneous, containing images from various sources. For example, the ISIC 2020 challenge contained images from 4 different countries. Nevertheless, merging of individual datasets into larger composite datasets requires accurate reporting of characteristics and metadata, and it risks magnifying bias if these characteristics aren't transparent. Whilst the open access datasets we identified have undoubtedly stimulated a great deal of research, going forward with the ultimate aim of deployment of AI for clinical uses in the future, datasets should be representative of the intended population where developed algorithms will be deployed. This is a big challenge, and systematic prospective data collection of images with associated metadata may be required to reduce selection bias and to best represent the populations from which they are acquired. And I believe Professor Fleming may have a few comments to add to in his talk about producing standardized real-world datasets. Potential issues stemming from digital health inequality are now becoming better recognized. For example, journal editors are now requesting demographics of population cohorts used in training of algorithms, including ethnicity and race, to be reported in research papers. There's new funding for projects with the aim of reducing inequality in digital health. And one example of this is a new project which our collaborators in Birmingham in the UK are leading, called Standing Together. And the aim of this project is to develop standards that ensure datasets underpinning AI systems are diverse, inclusive, and promote AI generalizability. The project is exploring how AI datasets should be composed, with who should be represented in the data, and also how this information is provided through dataset reporting. The project is currently in progress, with an e-Delphi exercise underway, consulting relevant stakeholders, including healthcare professionals, patients and public representatives, ethicists, policymakers, and computer scientists. Our review had a number of limitations, which I'd like to highlight before finishing. So datasets are frequently being updated, uploaded, and deactivated, and our review it only gives a snapshot in time. Secondly, when completing the review, we found that some algorithms were trained with images from online atlases, and these are different to datasets in that their primary purpose is education, and they may contain images over many web pages rather than in a single file. We did look at some of the atlases we found incidentally from our searches, but our search strategy wasn't specifically designed for atlas identification, so I haven't gone into any details about these in our talk. Finally, we found 8 restricted access datasets, but we didn't apply for institutional approvals or pay any fees to access these datasets in full, and so we couldn't review them to the same detail as the open access datasets. Regarding other areas to explore, an important area to focus on are some technical aspects of digital image acquisition and processing. A number of groups have demonstrated that technical factors such as rotation, color balance, and even the presence of surgical skin markings and rulers, as mentioned earlier, can all affect the diagnostic accuracy of algorithms. And the technical properties of images in these publicly available datasets warrants further exploration. I'd like to conclude now with a few points. So we found substantial variation in the reporting of key characteristics and metadata in the datasets that we identified, and this highlights the need for standards and recommendations for metadata reporting. We also found restricted geographical distribution of images and underrepresentation of certain groups of people, which has implications for algorithm generalizability. We hope that in the future, we can work towards transparent, inclusive, and representative datasets to ensure that the algorithms that we develop can benefit individuals of all backgrounds and skin types. Thank you very much for listening.